everyone. I'm Megan Bryden, and I'm coming to you from Dartmouth, Nova Scotia in Canada. Our team are thrilled to present two original research studies on weight bias and stigma in radiography. One study was focused on the imaging setting, and the other was in therapy. Since the studies were done in Ontario, Canada, at McMaster University and Mohawk College, we recognize and acknowledge that these institutions sit on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. I myself am coming to you today from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. Acknowledging the Mi'kmaq ancestral territory is our way of showing respect for and honoring our shared treaty relationship. I invite you to join in moving forward in an atmosphere of understanding, dignity, and respect towards reconciliation. I would like to recognize that in Nova Scotia, we are home to 50 African Nova Scotian communities whose culture, heritage, and histories have been and remain a key part of this province for more than 400 years. For generations, African Nova Scotians have experienced inequities due to systemic racism in Halifax and in Nova Scotia, and still do so today. Okay, so this is our map for the webinar today. We'll explore concepts of weight bias and stigma, take a look at the empirical research that covers the impact of weight bias and stigma on healthcare outcomes. The highlight of this webinar will be the presentation of our two original research studies on frontline radiographers' perceptions about weight bias in their practice, and then we'll wrap up with strategies for mitigating weight bias and stigma in radiography practice. So I will be covering the background and the literature on weight bias and stigma. Marsha will segue into the research methods for the two studies. Sarah and Alexa will present the imaging and therapy studies respectively, and Tom will conclude with a summary of the two studies and suggested future initiatives. To be fair, our secret goal for this webinar is to generate interest in this international audience to consider future studies in this area. Okay, so as I mentioned, I'm going to talk about weight bias to familiarize you with the background of the study. But before we start, I wanted to talk a little bit about biases in general. So biases are a natural part of the human experience. They are an evolutionary survival tool that has allowed us to make fast and even life-saving decisions. Biases are informed by our experiences, environment, culture, society, but sometimes they can lead us astray. Biases can be implicit or explicit. Implicit biases are unconscious beliefs or stereotypes that may actually be different from our conscious beliefs and may lead to unintended consequences and harms. Addressing and even recognizing biases can be challenging because they are so often unconscious, making them a bit tricky to notice in ourselves. And a note of context here, a lot of weight bias and stigma is rooted in societal expectations. The phenomenon of weight bias and stigma is not universal. While many cultures welcome and celebrate bodies of all shapes and sizes, this is regrettably not the case in much of North America and Europe. So weight bias and stigma are the negative attitudes about individuals in large bodies, as well as the concept of obesity itself that literally means to eat oneself fat. This includes social rejection, judgment, or discrimination of an individual with a large body habitus. Weight bias is rooted in the false assumptions of a large-bodied person's lack of discipline, lack of self-control, and failure of personal accountability. Although nearly 1/3 of the world's population have large bodies, weight bias and stigma are still broad-reaching, impacting access to education, employment, and basic health care. Research has shown that genetics, environment, stress, comorbidities, and medication may influence person's body habitus, and it is not simply calories in, calories out. In spite of evidence that intentional weight reduction strategies activate powerful compensatory biological responses, such as increased appetite and decreased metabolic rate, that render intentional weight loss unmaintainable, and in fact promotes weight regain, in the long term, many health providers continue to recommend weight reduction strategies to large patients. The Lancet and Nature separately released position statements addressing weight bias and stigma. Along with recognizing the prevalence of weight stigma in healthcare and its effects, they acknowledge that the weight stigma is also prevalent in health publication and literature. Research funding tends to be skewed towards behavior or lifestyle interventions. These factors contribute significantly to publication bias of how large people are represented in the literature. Patients with a large body habitus experience weight stigma and discrimination as a direct result of how their body appears, with judgments of their health status being made prior to investigation or without gathering complete medical history. As a result, health concerns are often dismissed or falsely attributed to their body size rather than investigated for possible and often typical causes. This is known colloquially, as fat broken arm syndrome, where a patient presenting with a broken arm is confronted with a healthcare provider who is concerned that their body, more concerned about their body habitus than treating the presenting medical problem, which is their broken arm. That's a bit tongue-in-cheek, but it speaks to the experience of many folks who have large bodies when interacting with the health system. There's direct harm caused by weight bias and stigma that affects access to adequate care, damages health, and is particularly prevalent in patients who have multiple intersecting identities, such as racial minorities or patients with disabilities. Large patients may avoid or delay healthcare interactions because of health provider weight bias and stigma, prior weight discrimination or distraction, weight bias and stigmatizing experiences resulting in negative engagement, poor health outcomes, advanced disease processes at diagnosis, misdiagnosis, and increased morbidity. Many comorbidities and conditions have been linked to large body size. However, I challenge you to consider that if an individual with a large body delays access to healthcare because of judgment and or prior bad experiences, it stands to reason that when they do ultimately seek care, they may present with a higher level of acuity or advanced disease state as a result of not seeking timely care. There is a real social determinants of health interaction here that goes beyond pathophysiology. But I digress. I'm happy to chat about this more offline after the webinar if that's something that interests you. Righto. So, health professionals have an obligation to treat all patients equitably. However, weight bias and stigma have been found across many health professions. Radiographers or medical radiation technologists, that's what we call radiographers in Canada for better or worse, are expected to provide care in an unbiased manner that respects the dignity, privacy, and autonomy of our patients. Weight bias and stigma undermine that directive. In the medical radiation sciences literature, large patients have often been described from a deficit perspective. This means using language that describes a person or situation using negative verbiage implying inherent deficiencies. Even studies attempting to explore the harms of weight bias and stigma in radiography have phrased questions from a deficit perspective, asking participants to describe challenges in carrying, imaging, or treating patients with large bodies. Many seemingly objective papers still open with the classic obesity epidemic background for context, even though that is the exact rhetoric that the papers are intended to confront. Deficit language can indicate underlying biases where a large patient is described as challenging, difficult to position, time-consuming, irritating, or blamed for limiting the ability of surface anatomy palpation. Inclusive language, on the other hand, would phrase our skills in caring for large patients, such as our ability to accommodate, adjust, account for, and modify our procedures to provide this population with an empathetic, best possible universal care. Radiographers care for a tremendous volume of patients, needing to accommodate and adapt care for a variety of patient populations. Determining frontline radiographers' perception and attitudes towards large patients, as well as weight bias and stigma in their practice, identifies areas where this may impact care provision and highlight potential gaps in understanding and indicate areas for improvement. I will now hand it over to Marcia, who will share the methods of our study.
Marcia is a member of the International Society of Radiological Technology and is the ISRRT America's Regional Education Director. I'd like to personally credit Marcia for putting together this webinar for us today. And Marsha's research interests are in advancing practice for radiographers and promotes a research environment for frontline radiation practice. Marsha is going to talk to us about the methods of their study.
Hello, my name is Marcia Smoke. I live near Hamilton, Ontario, Canada. In fact, I live very close to Niagara Falls. The section of this webinar, my section, will be on qualitative research methodology. The purpose of this study, as was explained by Megan, was to understand radiographers' thoughts on weight bias and stigma in their practice. Thus, a qualitative approach was used. So qualitative research is important. It addresses the how and why research questions. It enables a deeper understanding of the experience and the phenomena. So we wanted to understand the experience of frontline radiographers on weight bias. So this qualitative research was a perfect fit for this study. The data collected for qualitative methods is classified in three broad categories. We can get data from interviews, we can get it from observation, or we can get data for qualitative research on record review. So interviews, we used one-on-one interviews. So we interviewed frontline radiographers. And this provided rich data. You know, when people start talking and answering your questions, you get a lot of data. And this provides useful insight, which can be gleaned. There are many, many advantages to qualitative research, and some of these are listed on this slide. Unlike quantitative research, in which there's a hypothesis, and it's stated, and then it's tested with strict controls, in qualitative research, the rich data is descriptive in nature, and it allows access to the depth of experience of the subjects that we're interviewing. New topics come up, and these can be explored. The results of qualitative research can be used to generate new hypotheses and new questions, and it also can answer the question, why and how? Well, although we talked about the advantages of qualitative research, we know that there are also some challenges to collecting valid and reliable data from qualitative research. So if we consider one-on-one interviews where the researchers talking to the respondent, the researcher is an integral part of the process. So the data collected can depend on the rapport with the subjects, body language, and researcher bias. So for example, if we ask a question to a subject and they answer it, if the interview says, oh, that was an excellent response, that really is leading the interview. And the data is not as valid when the interview actually makes a value statement. So the interviewer must be skilled and trained to reduce subjectivity in these studies. We're going to find these studies that both Sarah and Alexa were coached to be interviewed, they were coached by experts. In addition, they practice interviewing with a pilot interview. The other challenges of qualitative research is reducibility and generalizability of the results. Well, these can be addressed by accepting thematic analysis approaches. Ultimately, the generalizability will depend upon the study population and the experiences that they bring. Well, data collection for interviews is descriptive. So there's a lot being said. The transcripts are coded. First of all, they're recorded, and they're indexed to identify common themes and elements. and they come up quite quickly. This is called thematic analysis. So although the sample size is small compared to quantitative studies, the themes are constructed from the data and the sample size is determined within the researcher looking for data saturation. That means that as we're interviewing people, if we find out after 4 or 5 that everybody is saying the same thing, we've got our themes and we've got data saturation. Scientific rigor is extremely important for any research. And for qualitative studies, we look at validity and reliability of the results. At the heart, validity stems from the quality of the interview questions. So the interview questions for qualitative research are guided by subject experts, the literature review, that's the evidence, and they're pilot tested. And this was done for this study. Anyone who has ever made questions, especially for qualitative research, realizes that actually asking the questions in a way that is not leading and trying to get the information that we want is extremely hard. But this must be done for validity. Well, reliability comes from careful documentation of the interview analysis. These interviews were recorded and the thematic analysis was done. So themes come up. This was done by 2 people, not just the original researcher, but by another. So having a second independent analysis addresses reliability. You will hear from Sarah and Alexa that these studies had great attention to scientific rigor. As we mentioned, the questions need to be grounded by the literature, by the evidence. So evidence for weight bias and stigma was searched in peer-reviewed databases that are listed on this slide. The literature for both studies included more than 65 articles that were in English. Opinion articles and non-peer review articles were excluded from the evidence. So there was a lot of evidence and study that was looked at before the questions were made. We did note that there was a lack of evidence from Canada on weight bias and stigma, and limited papers on weight bias and radiography. There was also very limited articles on weight bias and radiation therapy. But there were many articles and studies on weight bias and stigma in healthcare. And these themes were picked up through this, and they were reviewed, and they formed the basis of the questions that we used. The qualitative sample size is very much smaller than for quantitative studies because, as we said, a large amount of data results from very few interviews. The large data set supports an in-depth data analysis. These studies that you're going to hear interviewed a small number of participants, but this small number produced many single-space pages of data. There was a large amount of rich data for these studies. The radiographers were recruited for the study by the supervisors. So Sarah is now going to present her results of her study on weight bias in radiography.
Dedicated herself to exploring how these issues intersect with healthcare, aiming to create meaningful change. As a recent graduate with a medical radiation technology designation, Sarah is eager to continue contributing to the field of combining her academic knowledge with her passion for improving social outcomes. Thank you, Sarah, for sharing your results.
The 6 themes established through the thematic analysis included hospital resources, radiological concerns, attitudes and perspectives, communication assumptions, lack of education and training, and the way forward. Hospital resources, or the lack thereof, was a category that encompassed many discussions surrounding size-limiting equipment. Many participants described the lack of size-inclusive equipment in their hospital, which included wheelchairs, waiting room chairs, and gowns. One technologist told a story about a patient who brought her own bariatric gown to every appointment and hospital visit because the gowns provided were not large enough to fit, and she felt uncomfortable wearing two. If the technologist did have the appropriate equipment at their hospital, many mentioned that it was inaccessible and would require some searching throughout the hospital to find. Additionally, some radiographers mentioned issues using their large equipment due to spatial limitations in the hospital, including difficulty with space in change rooms, x-ray rooms, and patient rooms. This discussion shows that hospitals are designed without considering the general population. When you come to the hospital, you shouldn't have to worry about resources not fitting your body. Radiological concerns was a category that encompassed equipment limitation and the negative outcomes associated with these shortcomings. Discussions about these issues getting the proper technique for larger patients led to repeats, poor image quality, and ultimately more dose for these patients. These issues spurred comments from participants questioning the worth of imaging large-bodied patients. There were also conversations about the size of the CT bore and X-ray table, as well as weight limitations. Multiple MRTs shared stories about having to turn large-bodied patients away due to inadequate equipment size and weight limits. Larger patients are not only receiving more dose and subpar imaging, but are also being denied access to healthcare due to equipment limitation. When participants were asked if they had witnessed weight bias in the healthcare system, 8 out of 10 identified the experience. Some recalled specific examples, whereas others responded positively, but no details were provided. Many technologists explained that comments were a coping mechanism, a joke to provide humor, or an expression of frustration and exhaustion. Participants insinuated that some reasons could be burnout, understaffing, or a lack of support and equipment. The attitudes and perspectives discovered throughout the project show that weight bias is not only present in radiography, but it's often being justified. As we all know, there are serious staffing issues across Canada in many healthcare fields. Many participants discussed the lack of enough staff to move a patient safely, causing these technologists to be callous towards larger patients and view them as difficult, stating that they are put in a position of hurting themselves because there isn't enough staff to move a patient safely. Some MRTs justified the comments by citing the lack of support from other healthcare workers when performing portable x-rays. One participant stated that the lack of support is what sparks these comments. This comment shows that technologists may be frustrated with transferring larger patients and positioning these individuals without assistance, specifically from nursing staff. Many participants also believe that large-bodied patients means extra work. Due to this negative connotation, large-bodied patients receive negative attitudes because technologists parallel their physical and mental exhaustion with patient size. As mentioned in the section about radiological concerns, there needs to be improvement in assistive devices and in X-ray equipment itself. Although the technologists explained why they believe weight bias is occurring, a patient should never be a part of a joke, and a system of reporting inappropriate behavior should be examined. One technologist shared a story about a senior technologist making a crude comment, saying the technologist asked the patient to get up and walk somewhere, and the patient said, "Oh, I can't move." And the technologist replied, "Well, you got to the fridge somehow." Unfortunately, this participant shared that they felt uncomfortable challenging this senior technologist. This comment was said to a patient, and many other technologists confirmed that patients may overhear remarks made about them. Moreover, the comments mentioned in the interview were not just made by technologists. Porters, nurses, and doctors were also guilty of weight bias. Although there are many problems with weight bias in the field of radiography, there also appears to be similar issues in multiple other healthcare professions. A patient should never be mistreated regardless of the conditions in the workplace. We have all heard the saying, communication is key. However, this study showed that communication with larger patients is inconsistent. or even non-existent. When participants were asked how they discussed the adaptations they use with larger patients, there were varying responses. Some participants said that they would talk to the patient directly, and others said it was an uncomfortable topic and would not directly explain what was happening to the patient. Every patient deserves the right to know what is happening in their care, regardless of their physical characteristics. As a society, healthcare is moving in the direction of patient-centered care. Nobody knows their capabilities more than patients themselves, so instead of making assumptions based on size, the technologist needs to communicate openly and honestly with the patient. The communication issue may also come from the constant push from people higher up to have faster turnover rates. Although radiography technologists need to be time sensitive taking x-rays, has become similar to an assembly line. One participant told a story about working at a clinic, saying, "I remember being told very clearly that if a patient was too difficult or if they felt like it was going to take too long to get the case done, then they were to not do the case." Another participant said that there's a maximum of a 10 to 15-minute interaction, and they usually don't even bother introducing themselves. These comments demonstrate that patients are being treated like a number. There is no time for explanations or introductions, and if a patient is deemed difficult, the x-ray may take too long and thus decrease the turnover rate. These negative ideas are consistently being voiced, making it difficult to break the bias that a larger patient means more work and a slower exam. Healthcare professionals often make assumptions regarding a patient's size. For example, the health problems are caused by their larger size, the patients are not physically active, or that they overeat. One technologist stated that they have heard comments like, "I couldn't let myself get that big," or at some point you just think that you would take better care of yourself and stop eating. These are presumptions and creating a toxic healthcare environment. Across responses, respondents commented on a lack of training, education on working with larger patients working with large-bodied patients. When MRTs have no training in adaptations in positioning and technique, more educated guesses and repeats occur, leading to an increase in dose. Education in medical radiation sciences require extensive learning and hands-on skills training in patient care, interprofessional collaboration, and physics. This education prepares students to work and thrive in a healthcare setting. However, specific populations are overlooked in the education and training. Practices amongst a peer group provides limited variety to what is actually seen in the general population. As many technologists mentioned, students seem shell-shocked when interacting with larger patients, substance users, and people experiencing homelessness. These comments show that there needs to be more education regarding this topic, beginning with targeted training for students and seasoned professionals. Healthcare workers need to be educated about the many factors that can impact body habitus. These assumptions and educated guesses create a harsh, uncompassionate environment for patients seeking care when they're the most vulnerable. All patients deserve equal treatment and care. There are multiple discussions with the participants about how we as a community can reduce bias and help larger patients get the care that they deserve. One suggestion was to add modules regarding weight bias and ways we as technologists can reduce our bias in the continuing education hours required by our regulatory college each year in Canada. Another suggestion was that rather than teaching some of the skills to students that have become obsolete, information sessions regarding the current problems in the healthcare system might be more effective. Training could include the topics of weight bias, the 2S LGBTQIA+ community, disability discrimination, women's health issues, racism in healthcare, the disease of addiction, and the homeless population. Not only would these topics help students, but courses or information sessions of this nature could also be helpful for technologists already working. As many participants stated, that reminders of patient care might seem silly, but are often necessary. In addition, the literature discussed how having a good role model is one of the most effective ways to reduce weight bias and is often more helpful than in-class education. This is why it's essential to continue to educate yourself on the issues facing patient care and healthcare so that you can be a role model for students and new technologists.
Thank you, Sarah, for that. Some quite confronting things to think about that you discussed in that presentation. So thank you very much for that. Moving on to Alexa. So Alexa is a passionate fourth-year radiation therapy student at McMaster University, eager to graduate in June, coming up very, very soon. She seeks to make a significant impact through both research and compassionate care for cancer patients and their families. Driven by her compassion, she chose to conduct the research project Weight Bias in Radiation Therapy, aiming to explore how biases in patient care can affect treatment outcomes. Through this work, Alexa hopes to highlight the importance of reducing bias and enhancing ways to improve the quality of care that patients receive. To find out more about Alexa, you can check out her LinkedIn page. Alexa Wolak is her surname. Thank you, Alexa. Looking forward to seeing your talk.
Hi everyone, my name is Alexa and now I'm going to be going over my part of the study which is titled Beyond the Scale, and it investigates weight bias in radiation therapy practice. So here's just a brief overview of what I'm going to be covering. So it includes the introduction and background, the methodology, the results and discussion, and then overall what we concluded. So what is weight bias? So weight bias refers to the prejudice, stigma, and discrimination against those living in larger bodies. It remains a significant issue in healthcare. However, its impact on fields like radiation therapy still remains significantly underexplored. This qualitative study investigates the radiation therapy perception of weight bias, aiming to improve patient care and workplace dynamics. So in Ontario, approximately 35,000 patients receive radiation therapy annually. And despite the ethical standards and the equality, diversity, and inclusion EDI values that are endorsed by workplaces in the CAMRT, weight bias still remains highly prevalent. It's often underestimated compared to other forms of discrimination, and it's usually socially tolerated through derogatory humor, whereas similar comments about religion, disability, or race are universally condemned. So literature shows that individuals with larger bodies are frequently unjustly perceived as lacking motivation, lacking willpower, and this results in challenges in healthcare settings. This bias underdetermines patient-provider relationships and contributes to poor outcomes such as depression, eating disorders, self-devaluation, avoidance of care, and overall diminished patient experiences. So BMI is a commonly used tool for determining obesity, but it does have significant limitations. It fails to differentiate between fat and muscle, it does not account for fat distribution, and it overlooks age, gender, and ethnic differences which are crucial for understanding body types. Originally, BMI was developed in the mid-1800s using data from white middle-class males, and it just does not adequately represent diverse populations. Additionally, weight is influenced by a complex interplay of environmental, dietary, social, cultural, and genetic factors, making it more than just a matter of calories in, calories out. We chose a qualitative study approach similar to Sarah's for its ability to provide in-depth understanding with minimal to no risk to participants. Radiation therapists, both practicing or retired, were selected for the study and identified by the research supervisors. They were then contacted via email by myself, and the data collection involved 9 one-on-one semi-structured interviews conducted through Zoom. All study materials were approved by HIREB, which is our ethical board, and participants provided both written and verbal consent. The interviews were guided by 6 questions that were developed from an in-depth literature review and a previous study, which was Sarah's, that we based it on. We used a software named Temi to transcribe the Zoom recordings, and then we conducted 2 separate thematic analysis following the Braun-Clark approach to ensure validity. Consensus was achieved on most categories and themes, and the themes were further supported with direct excerpts from the transcripts. For the demographics of our study, we interviewed 9 radiation therapists across Canada with a 7-to-2 female-to-male ratio. Participants included a diverse range of experience levels and areas of expertise. We had 1 junior therapist, 2 novice therapists, 2 intermediate therapists, and 4 expert therapists. They were all of varying roles, so some of them were in treatment planning, others were educators, others were in research, clinical practice, as well as specialization in brachytherapy and mold room procedures. Our double-blinded thematic analysis identified these 6 key themes. So these themes include ergonomics and physical demands, patient care considerations, attitudes and perspectives, treatment considerations, hospital resources, and pathways to improvement. And I will go into each of these in a little bit more detail in the next couple of slides. So this is just kind of a table that we made, which kind of goes into more detail of each subtheme. So radiation therapists require significant physical stamina and strength to perform their duties effectively, often involving moving and lifting patients to reposition them for treatment. Concerns about ergonomics and physical demands emerged prominently in this study, with all 9 therapists expressing worries about back injuries or other mobility-related issues. These concerns stem from a lack of adequate mobility and transfer support equipment, as well as insufficient staffing for patient transfers. Some of the therapists even reported having to shorten their breaks to assist with patient lifting, highlighting the issues with workflow and support. The question, "Can you describe your experience in treating larger-bodied patients?" led therapists to reflect on their own physical health challenges. Such concerns can lead to frustration and foster subconscious negative attitudes towards larger patients. Additionally, the concern of physical strain may push therapists to prioritize efficiency over patient comfort, potentially resulting in rushed or less attentive care. The second key theme identified was patient care considerations, particularly regarding radiation dermatitis. This condition, a common side effect of radiation therapy, involves skin damage and is notably worsened in areas of skin folds and friction, such as the breast and the buttocks area. Radiation dermatitis can result in fungal infections, skin breakdown, and blistering, and patients with larger body habitus who have more skin folds often face these side effects in greater severity. When asked what challenges and concerns do you believe that larger bodied patients might experience throughout the course of their treatment, all 9 interviewed therapists cited skin reactions as a primary concern. Numerous therapists indicated that this was a common sighting in patients with larger bodies. One therapist even saying, "The patient said to me, 'I think I have a fungal infection in there,' and I responded, 'Yeah, well, it's because of the way your breast is hanging.'" This poses the question, are these severe skin reactions simply accepted as an inevitable part of treating larger bodied patients, leading to passive management, or should more proactive measures be implemented to prevent these painful conditions, such as educating the patient on proper skincare, supplying hydrocortisone creams proactively, just to manage these issues before they escalate. Another therapist highlighted this concern by drawing the comparison to the diligent care provided to patients with skin cancer and expressing how these patients are constantly being sent for assessment, but the exact same care and consideration is not there for the larger body patients, even though we know that they are at a higher risk. Attitudinal considerations are not a standalone theme, and they intersect with various aspects of practice, influencing the other themes as well. This section aims to highlight these connections and provide an opportunity to examine and challenge our internal biases, rather than placing blame on individuals for their subconscious behaviors. When asked if they had experienced weight bias in their practice, 8 out of 9 therapists identified the experience. This bias was often rationalized, with many attributing it to frustration. Common issues included misconceptions about larger-bodied patients, as well as the subconscious use of dehumanizing and stigmatizing language. Understanding these intersections is crucial for addressing and mitigating bias in practice. So, when asked about weight bias, 8 out of 9 therapists reported encountering it in their practice, indicating that such bias remains prevalent and sometimes even rationalized. For example, one therapist noted using fat humor as a coping mechanism, which can unintentionally reflect implicit biases and create a divide between healthcare workers and patients. Negative nonverbal cues like eye rolling were also observed. And therapists often also made assumptions about larger-bodied patients, presuming limited mobility, comorbidities, despite the complex factors influencing body weight. Treatment considerations are well represented in existing literature, which frequently highlights the fundamental importance of positioning patients in radiation therapy and the struggles that might come with the treatment of larger-bodied patients. Some of the common issues that were consistent between the literature review and our participant responses included CT and treatment table weight limitations, the bore sizes, narrow table width, inconsistency with tattoo alignment, plan optimization, so the difficulty to reduce hotspots, image quality, and the fact that treatment techniques are not always applicable to all patients, VMAT, for example. For larger bodied patients, increased tissue separations can lead to reduced dose uniformity and the need for higher energy photons to maintain effective treatment. Hotspots, defined as areas receiving doses above 100% of the prescribed amount, are a concern. And some therapists worry that these are often accepted as inevitable rather than optimized to their fullest potential. These findings underscore the urgent need for advancements in equipment and treatment strategies to ensure equitable care and improve outcomes for patients of all body sizes. Participants also identified hospital resources as one of the important limitations that can contribute to weight bias and suboptimal patient care. From the main waiting room chairs to the treatment room beds, many issues were identified, contributing to the discrimination of larger-bodied individuals. One therapist recalled having issues with the size of the exam rooms, saying that sometimes bariatric wheelchairs don't fit through the exam room doors. This indicates that the built environment is not always created with inclusivity in mind. The literature review recommended using pre-screening protocols in order to prevent patient embarrassment and guarantee that individuals of all sizes can comfortably access healthcare services. Our fifth theme is hospital resources. Therapists also raised concerns about treating patients with larger body sizes due to equipment limitations. Issues include exceeding weight limits and, again, struggling with the narrow treatment tables. Some therapists reported using restraints to prevent falls or having to even refer patients to other centers because their size exceeded the weight limit's capacity. For example, one therapist mentioned sending a patient away to a further center because their weight limit exceeded the limits of the treatment table or scanner. So CT scanners and linear accelerators have weight limits of approximately 400 to 450 pounds, and MRI machines are limited to only 330 pounds. This highlights the need for improved equipment and protocols to provide equitable care for all patients. So our last theme is pathways to improvement. Addressing weight bias in healthcare is essential for delivering equitable care, and a multifaceted approach is necessary to drive meaningful change. Education stands at the heart of this transformation, serving as a fundamental strategy for the reduction of weight bias among healthcare practitioners. All 9 therapists interviewed identified research as the most significant factor for change, followed by inclusivity, infrastructure, and equipment adjustments. To combat weight bias effectively, we must integrate comprehensive training programs on weight bias with structural and procedural improvements in healthcare facilities. This includes upgrading infrastructure to accommodate patients of all sizes, implementing clear imaging guidelines, and investing in specialized equipment like bariatric CT scanners. By combining education with these enhancements, we can improve patient experiences, ensure equitable care, and foster a more inclusive healthcare environment. When conducting the interviews, several limitations must be noted. So the small sample size of 9 therapists and an 8-to-1 female-to-male ratio limit generalizability. Selection bias may also arise from participant connections and availability, and recall bias could affect data accuracy despite using structured questions. Social desirability bias may also influence responses, even with assurances of confidentiality. Despite making efforts to reduce these biases, they are still possible and can impact the findings. Awareness of these limitations is crucial for interpreting the results and guiding future research. Thank you.
Thank you, Alexa, for taking us through a lot of that stuff particularly with radiation therapy and how that works and that. And I think there's even a lot that that I didn't even realize that may occur from that. So it's I've learned quite a lot. Thank you very much. Moving on to our final presentation for this evening or today, and that is by Tom Farrell. So Tom has worked as a clinical physicist for 3 decades in radiation therapy. A particular joy of that role is the luxury to be involved in research and education, working on interesting questions with the brightest of colleagues. Now retired from clinical service, he does continue to indulge his interest in various research projects. Thank you, Tom, for your presentation. And I will just remind people before we go to his presentation, just to please put any questions that you have in the chat or in the Q&A section, and we will go through them straight after this presentation. Thank you.
Hello, everybody. My name is Tom Farrell, and I'm the final speaker of the session. Before I start, I'd like to acknowledge what a pleasure it was working with Alexa, Sarah, Megan, and Marcia. Now, I'm going to talk about common themes between the studies, the path forward, and future work. And I'll start by saying that we saw very similar themes, even though these were in different fields in the radiation sciences. And I think this speaks to the validity and reliability of these studies. Let's look at the themes. On this slide, I've tabulated themes identified in the radiation therapy study and the radiography study beside each other for easy comparison. The themes on this slide are primarily patient-centered themes. Both studies identified hospital resources or lack thereof and how that affects the patient experience. Secondly, they both identified attitudes and perspectives of staff and how those affect the treatment of these patients. They also identified in their individual fields the technical challenges posed by large-bodied patients, and these look at things such as image quality and also quality of radiation therapy treatment. A second set of themes are primarily staff-centered themes. The first one, in radiation therapy, they identified as ergonomic considerations, which deals with how staff interact with patients at the physical level. Now, staffing is different between radiation therapy and radiography, and a similar theme was identified in radiography, looking at support for staff and communication. Both studies identified education and training as either a major theme or a sub-theme. And both studies looked at what are the pathways forward for improvement, both at the institutional level and the staff level. The last theme from both studies was what is the way forward? And really the way forward is recommendations based upon the interviews in the study. Both identified more education and training. Both identified institutions invest in size-inclusive equipment, both to make it safer for the patients and for the staff. Both decided that guidelines should be developed for technical imaging protocols to deal with the technical challenges. It was noted that staff support issues and burnout should be addressed, and it was also noted that audits of equipment and procedures should happen on a routine basis to address the challenges. So at the end, we asked the question, what future directions are suggested by these studies? A simple one for everybody listening to this presentation is a self-audit. What are your perspectives? What are your attitudes? A second would be a department audit for the institute at which you're presently working. What equipment do we have? Is it appropriate? What are our protocols? Are they appropriate? What should we change? How could it be changed? A third theme identified was education and training. And you could ask the question, where is it appropriate to do that? Or there are many sites and locations where it's appropriate to do it. Continuing education for those who are currently working in the field, education at the level of the training student. Should it be something that a national body looks after? These are questions that you can ask yourself. Finally, these studies looked at subjects from our little corner of the world. And to support these studies, additional studies should be done in different locations, looking at different populations of staff and patients to support or contrast the results we had here. And with that, on behalf of myself and my colleagues, I thank you for your attention, and we welcome feedback and discussion.
Thanks, Tom. Thanks very much for that that little conclusion and roundup of the all of the research that has gone on. I'd like to invite all of the speakers to please turn your cameras on, because I'm interested in asking quite a number of questions. So hello to you all, and thank you very much for joining us with this. Firstly, look, I want to just start by just thanking you all for kind of sharing your research and really highlighting this this issue, I think, within the profession itself. And that personally, I'm actually quite shocked, I think, with a lot of the information that kind of came out of there. And that, look, I have a background in pediatric radiography, so we don't see a lot of this weight bias and stigma. We do see a little bit of it, but we don't tend to see a lot of it in that. And so seeing how prevalent that is, I think, in other areas, and what the effects are, and what I guess I hadn't really kind of considered the things from I guess a resource perspective and a hospital perspective as well. So I'm really glad that it's kind of come out. Megan, let's start with you in terms of the in terms of your talk and some of the questions that I've kind of come up. And please, for anyone that has any questions, please pop them into the chat as well. But I'm going to start with you, Megan. In the literature itself, what are the effects on mental health for the patients in particular regarding the situations such as things like the broken arm syndrome that you talked about?
Definitely, like, it's very demoralizing. And again, I come as somebody as well, like with the lived experience as a fat person. So, you know, it's sometimes hard to parse out, like, what is it, my bias, or is it like the real world experience? But the reality is, like, it is demoralizing. And at the end of the day, if you have people who ultimately are avoiding seeking care because of previous poor experiences or presumptions of poor experience, and just having their health concerns disregarded. You know, if you have migraines, it's because you're too fat. If you have a broken arm, you're too fat. You know, if you need knee surgery, you're too fat. You know, all these sorts of things. And it's like, okay, but are you affording me as a person, as a human being, the same attention and investigation for care that you would provide for somebody who was in like a slimmer body? And the reality is, like, the evidence suggests that that's not the case. And also, like, that then becomes sort of this like self-fulfilling prophecy where people present with an advanced disease state. Well, it's because fat people like are inherently like higher risk or have advanced disease processes. But it's like, well, maybe that's the case in some situations. And part of what I'm trying to get at here too with this research is it's not automatically the case, and to give people sort of the benefit of due diligence and compassion rather than, you know, sort of blaming a person for like their body size. And I mean, I don't want to, like, I could talk about this for eons. I did see a question in the comments that kind of links to your question too, which is how do you communicate in weight neutral and not reinforce some of these biases? Because I know, like, inherently as like MRTs or radiographers, we don't want to do harm. We're not seeking like to be, you know, ignorant, if that's not quite the right word, but I think that it's so prevalent. Like, it's even like it's biblically adjacent, you know, like you're slovenly or whatever. Like, it's so deep in our subconscious. But I think one of the things that I think we've learned from other equity seeking groups and whatever is to not also pretend that it's not a thing. If you need to move my body or skin or whatever, tell me. Let me be part of it. Don't pretend like it's not more work, because I think, you know, it could be more work, and that's okay. It's okay if it's more work. It's okay if I need to help with some of the positioning. It's okay. But to then pretend things are fine, or, you know, kind of give somebody the cold shoulder and then talk about them behind their back when they leave the department, like that's not the way. You can talk about things, like it's just to be kind. And I think that's something we're able to do. We're very good at that. We're very good
Yeah.
at being kind.
And I think that's something that was highlighted in the research that you did was the discussion about things like there's a lot of I guess public attention about other biases that people can have in terms of gender biases and that it's and race, and it's just not socially acceptable anymore in that, but for some reason weight bias still is, and I think that's probably something that we can all kind of work on, and I guess in some cases calling it out when we see that behavior occur as well, right?
And then sometimes, like, I mean, not everyone is like intended to be like a warrior for justice, and you know, but like sometimes it's not laughing at a joke. Like sometimes it's as simple as like just not laughing. Or, you know, we had a comment in one of the radiation therapy projects about like somebody comparing people's sizes to Starbucks coffees. And it's like, okay, like, haha, but it's a pretty cheap joke. And sometimes it's just not laughing. And it seems so minimal, but like it's a very real thing, right? Anyway,
Yeah.
I could blather on. I'm sure other people want to talk.
No, that's good. And yeah, like I will say this, a lot of questions are coming through the chat and that, so I'm going to ditch my questions that I actually had for everyone. So you've got off the hook from my perspective, and I'm just going to go with what the audience has asked. And I guess this is kind of, you know, open floor now for anyone that wants to answer the question. And that, did you explore the demographics of the radiation professionals and their own experiences of weight bias, and how can we better support staff to minimize weight bias?
Alexa, do you want to speak to that? Because you actually had a question about the individual participants' experience in your study.
Sorry, could you repeat that question? I was just reading another question that was.
Yeah, no,
here.
you're fine. So the question was, did you explore demographics of the radiation professionals and their own experiences of weight bias, and how can we better support staff to minimize weight bias?
Yeah, so we had spoken with their. Did you explore the demographics? So for better supporting staff on how to minimize weight bias, like I said in the presentation, majority of people said that education was kind of the first way to support staff. We don't really know there's a problem until we reflect on it, right? So I think before heading into things like actual hospital resources, I think dealing with kind of the internal biases and being aware that you have those internal biases is kind of the first step. And then the demographics of the radiation professionals. Megan, do you want to help me with this one?
Sure. So an evolution. So just in the chronology of this work, Sarah did her study last year, and Alexa did her study this year. And in that, we realized that we didn't ask the participants about their experience. So we did ask them, and again, just sort of scratching the surface, we did ask participants in the radiation therapy study if they self-identified as having a large body. And I think 6 out of 9 did. But it did flag. Yeah, and it did flag the fact that we also have large-bodied health professionals working in this field, and that in and of itself is something that's worth investigating, like the experience of being like a fat health provider, and whether that, like, the perception of whether that diminishes um, your perception of value, or how seriously people take your advice, those sorts of things, is definitely something that we've flagged for future follow-up. But we did have more than half of our participants self-identify as having a large body. What does that necessarily mean? Who knows? Like I have a very large body, like in a comfortable in airplane seat body. So what I consider a large body and what someone else considers a large body, is one thing, but they did self-identify as having large bodies as well.
I think that's the thing. Like it's a very subjective thing, but at the same time, it also, even though it may be subjective, it still will change the perception. Well, I think it will change the perception of how they actually see others at the same time as well, right? A question has come through from Kadana, and thanks, Kadana, for your question.
Can I just come in on the end of that?
Oh, absolutely, Tom.
Okay, I'll go back to something that Marcia was talking about in her presentation, which was the methodology of this study. And we had a smaller number of subjects because it was a qualitative study, and that gave us access to richer data from the individuals. And I think, coming back to my last point, that more studies should be done. I don't think it should just be a repeat of our study. We can think of different ways of approaching it with larger numbers of people, and then we can start getting into the demographics. So I would say partly the methodology didn't really allow for as deep a look into the demographics of the subjects. But that's the whole joy of a qualitative study. It generates these sorts of questions, and then we can think about how do we go about answering them.
Yeah, absolutely. Thanks, Tom. Kadana has come through and just said, what advice can you give for health facilities in developing countries who may find it difficult to effectively allocate resources for weight or size accommodation?
I can tackle that if you guys want. I do love the sound of my own voice, so if you guys want to speak, flag. But I think the reality is, regardless of where you're working, everyone is limited by equipment constraints. And I think for a lot of cases, typically what happens is the patient is blamed for not being able to be accommodated by the machine, rather than it be, okay, our equipment doesn't accommodate all people. And I think the reality is, sometimes you will have equipment that does not accommodate people. Mm-hmm. And I think if you discuss that in a kind way, and in a not blaming way, like, you don't fit in our machine, it's our equipment can't accommodate you. And then some facilities that in my own research that I have determined have sort of a, like, not really procedure, but they have some, if in this case we can't perform XYZ procedure, then we will refer them to this or that place. So I think that, when you're in resource constraints, you can realistically, for any situation, only do what you can do. I think that people have become very clever in accommodating, maybe something's typically done prone and you're going to do it supine, or something like people have gotten clever in ways to kind of make the most of equipment that they can do. Understandably, like, when you're in equipment restraints, like, that is a limiting factor, not that the patient is, like, too big, if that makes any sense. Like, that's just kind of a shift in where, in, like, sort of like where the fault is the equipment, not the fault of the patient. And sometimes, like, there's some size planes that I don't go on when I travel, because I know that I do not fit in that seat. Like, that is just how it is right now. But I think that there's ways that you can manage the inability of the equipment to accommodate everyone in a way that maintains the dignity of the individual who can't be accommodated.
Yeah, absolutely. And it does kind of bring me to the next question that was asked in that. And I'm actually going to open this one up to Sarah or Tom. What are some imaging techniques and methods to improve image quality and avoid overdosing, etc., due to the weight bias?
Yeah, I can take that question. So a lot of the overdosing aspect of our research itself focused on the fact that the overdosing is mainly coming from having to do multiple repeats for these patients because of like body habits. Because a lot of radiography, we use landmarking based on bony anatomy. And a lot of her participants mentioned that it was very hard to kind of accurately feel where that bony anatomy was due to the larger size of these patients. And then that led to like kind of estimating where you were, or some people called it like educated guessing on where you were for these imaging, and then ultimately leading to having to do multiple repeats for reasons like that. One of the biggest things that I actually like learned from doing the research was that a lot of people don't really use the patients themselves as the resources that they are. Like they are the ones that are going to know their body their best. They are the ones that are able to point out those landmarks for you instead of you just having to guess where they are. So one of the things I started doing in my own practice was asking patients that are maybe larger if they can kind of point to where their hip bones would be, or like where their hips might be, things like that, and try to use them as their own resource. They're going to know their body their best, and then that kind of eliminates some of those repeats that you may be doing, and ultimately limiting the overdosing of those patients. Another thing was some of the patients mentioned, some of the participants mentioned using some like tips and tricks that are very specific to radiography. So if you're not a radiographist, you might like not really know exactly what I'm speaking to, but there was one participant that mentioned something like using the armpit of like the arm where the elbow joint meets as a landmark for where the hip joint actually, like the hip bone actually starts, like the iliac crests. So some things like that are kind of like tips and tricks that mostly work on a lot of people with body habitus. Obviously, it's give and take. Not everybody has the same length of arms, but some things like that that they've learned throughout their careers also help kind of guide us in what we can change in our own practices to better reduce those repeat imaging.
Thanks, Sarah. And I think that's also, I mean, that kind of brings me to a question that I was actually going to ask you anyway, and that is about the role that that you may have as an education provider in terms of ensuring that your students are aware of the different body habituses and looking at more than, there's more than one way to skin a cat, right? So looking at the different ways that you can actually position patients in that sense as well. Megan, you got your hand up?
Yeah, just to your point too, Steve, is that textbooks tend to be a very specific type of imaging is used as the example. And even, when you're doing sim or you're doing like clinical placements, you don't always see every sort of presentation or body habitus, body composition. My background's in peds as well, so you sometimes don't see like the kind of breadth of human experience. But I think part of it is acknowledging that like some of the examples that we're using in education like aren't doing our students any favors if they're only textbook but not real life. So I think that speaks to like using real examples, like, and not in like a shamey way, but just like, look, this person is 350 pounds, they're here for a PET scan. This is how this image looks. This is how you can optimize this with the settings that you have, and just having like a real conversation about how do we optimize what we're able to do based on like the actual real world scenarios, as opposed to this perfectly, like, I don't know, I don't even like the word perfect, because like what is perfect, but this very like lean example that's in the textbook or in our simulation.
Yeah, absolutely. Can you share any case studies or examples of successful interventions that have improved equitable treatment for patients of all body sizes?
I'm sorry that my internet has been going on and off, but
That's fine, Marsh.
The literature, Steve, did talk about some interventions and things that worked and things that didn't work.
Mhm.
So, for example, and probably Sarah and Alexa could speak to this more, things like wearing a heavy suit for half a day and doing your job. I don't know what those suits are called, to see that you could get some empathy for this. That actually was something that was suggested and actually had a fairly positive outcome. Education didn't seem to, but maybe Sarah and Alexa would like to speak to that.
Yeah, I can start off speaking to that. So I think that like when I did my literature review, when I was going through the program, there was a couple of things that I talked about in like our research that had a positive effect. So like I mentioned, a role model was one of the biggest things that was actually proven to be far more effective than actually like in-class education. Unfortunately, a lot of the research that is out there is either not in radiography itself or is not solely based on like radiographers. A lot of them were like medical student studies and things like that. And they were trying like education-based training with them. And then after a certain amount of months, they would kind of resort back to their original ways. And so they were using that as a guideline to say that like education maybe hasn't been as effective as they wanted it to be. And so that's when the role model kind of came in. And they said that when you're having somebody that you're seeing on a regular basis, that you're watching interact with these patients in an appropriate manner, in a good way, and finding ways to get imaging that is worthwhile and worth them coming to the hospital and getting the diagnostic quality that they need, then you are now like you are going into the world and you're kind of doing and acting the same way that they are. So through my training, as I said, like kind of similar to the last question that Megan mentioned, that when we were as students, the population that we practiced on in our learning was our student population, and that is really one size fits all. There was not a lot of variation in body sizes and even like personality itself, like people that are experiencing homelessness and addiction and things like that, like you actually see when you come into the hospital setting. So I do believe that with a combination of like having a good role model that kind of shows you the ropes and how you should be interacting and kind of teaches you the way, and also a combination of getting better education and like a hands-on experience and kind of working with these larger patients and working with these patients that are experiencing different parts of their lives, then that kind of gives us would be a more accurate kind of representation of what could possibly work in the future. But really in the literature, there was only the one couple examples about how role models are more effective than education. So that's where we are currently.
Thank you. And I think on the sorry, Megan, I'm going to get to you in a second, but I just on the flip side of that question was a question that's actually come up from Sharon, who's actually from Australia. Thank you, Sharon, for your question. And this is, can you share some stories or examples when larger body patients have had great care from radiographers or radiation therapists? So what are some of the results when patient-centered care is respectful or the care is actually done well?
That actually segues. I was just going to tag on to what Sarah was saying, in that some of the interviewers, some of the participants commented on, some points of pride, or how instead of something being a challenge, it can be something that you're really proud of. And we had participants that described, really wonderful experiences in providing care for patients and being proud of, being able to accommodate them or being clever about how to set up. The shortcoming of our research is that as of this point, we've only talked to radiographers. We haven't talked to patients. That's actually a huge gap in this body of knowledge. A lot of the patient experience is reflected in the gray literature. So like online, on Instagram, you hear stories of people like kind of having different experiences. We haven't, as a profession, really investigated what the patient experience is for good or for bad. And we did have some lovely comments from participants that talked about how they felt that providing care for large body patients was in line with, like, you know, person-centered care and equity, diversity, inclusion, and how it should be part of some of that just basic training. So we did have some nice comments, and maybe that's a point, Sharon, that we should actually also talk about some of the good feedback that we got, just about the experiences, again, of the radiographers providing care. We don't have anything right now of the experience of the patients from themselves.
Yeah, thanks, Megan. A question's come through from Saeed in India. His question is for Alexa about how to overcome the challenges of limited bore size of PET-CT gantry. He's working as a nuclear medicine physicist, and in routine he faces many large patients that they can't really move or their loyal patients around to go and search for another hospital for the services. So in order to resolve the issues, what do you think your opinion would be on that one, Alexa?
Hi, okay. Thanks for asking that question. So throughout my two clinical experiences, I haven't worked on a PET CT specifically. I've just worked on like regular CT machines, but I completely understand it's not ideal or convenient to be sending patients to different centers and potentially not possible in other places. But I think definitely opening the conversation and kind of, I guess, thinking of different ways that you could accommodate the patient size. For example, like if you're doing maybe like a lower body scan, like can you position them feet first, feet to gantry, or if they are, somewhere on the top, would it be beneficial if they had, would it be okay if they had their arms down rather than their arms up while being positioned? So yeah, I think kind of just finding ways that you can adjust the position so that the patient can still fit through the gantry and, be comfortable, rather than just kind of having this one standard position for all patients that might not always work. And then jumping back, I don't want to like jump back and forth, but just to the last question that we were talking about, I think it was about like the patient experience and whether any of us have had any examples from the patient perspective and, a positive experience. And through, again, the study was directly with radiation therapists, but I can answer that question through my clinical experience. We kind of like Megan had said, I think being very open to the patient and honest and letting them know when we need their help is really important. Like I did experience a breast patient with her arms up, and we did have to tape their arms. And, we explained to them why we had to tape their arms. We explained to them the benefits of taping her arm and why. And she was honestly really, really happy and grateful that we explained to her the reason things rather than just and them questioning why they might have that done to them, but not everybody else gets their arms taped. So I think just being open and honest to the patient can provide.
Yeah, thanks, Alexa. Now, just to everyone, I'm actually just going to apologize in advance because my dog, I think, is about to, it's the middle of the night here, and my dog is about to bark at a possum that's actually outside in my backyard. So I do apologize if you just hear a bark in the middle of the night. I'm sorry. Just looking ahead, how do we see the technology and evolving healthcare practices addressing weight bias in radiology and radiation oncology?
Me again. I can hop in, and then if you guys wanted to jump in after. We did actually, in our interviews, we had several both in across like the two studies that had talked about how their departments now had some chairs without arms on them, and how they had their most recent acquisition they had made sure that the table limit and the bore size were like the largest of industry standard. And so I think it's becoming part of the thought process around equipment replacement and around those sorts of things. If you go to the big conferences, you can see like open bore imaging options. And I think that the reality is that large bodies aren't going anywhere. If anything, there's going to be more and more of us all the time. So it seems like industry has kind of gotten on to how, like, to accommodate those with larger equipment. The other thing is, several of the respondents talked about how they have the availability of larger hospital gowns, and that they don't just have sort of one size fits all. They have options for folks. I know, like, when I was working clinically, I had a set of scrubs that were like mine, because my size wasn't in the pop machine of scrubs where you could go in and get. So, like, there are resources available, and there does seem to be sort of a shift where, instead of one person talked about there's one slider board for 5 units, now there's some folks that report like having higher, what are those lifts called? Hoyer lifts and sliders like available for every other unit and those sorts of things. So it is changing. It's just, that some of the older equipment takes a long time to work its way out of the system. But even something like having some wider chairs in the waiting room, or having chairs without arms, like those sorts of things all make a difference. Having a sturdy stool with a handle rather than like the plastic, one you get from Walmart, like for people to hop up and off the bed, like all those sorts of things seem to be kind of becoming more common.
Yeah, that's good, and I think the more we highlight this issue, the more that kind of thing in terms of resource allocation is actually going to be more prevalent, I think, in the future as far as this is concerned. I'm just going to ask one final question, which I think covers the last 2 questions that have been put into the chat all together, and this is just around instances of staff seeing concurrent discrimination from the same staff members themselves. So we're talking about things like weight bias, homophobia, etc., and that. So did we come across any of those instances in the research that you've done?
I can go ahead, Alexa, go ahead.
Oh, my comments just really quick. I haven't seen any directly linked to homophobia, but there was a lot of comments kind of in my paper that were linking disability to weight a lot. And again, kind of the presumption that if you are overweight, then you have a disability, or there was a lot of commonalities between disabilities and the weight.
Yeah, and I was just going to add that there was definitely some participants that mentioned like the same staff member over and over again with different examples of what they would say to larger body patients, because we didn't really focus on anything else besides discrimination based on weight and things like that. I didn't come across any other types of discrimination in that sense, but we weren't really like looking for that. But that's not necessarily to say that some of the same staff members weren't making similar comments. But again, a lot of the participants were speaking to what they've heard or seen and not what they've said themselves. So that's to kind of like hard to exactly say whether these staff members have seen any disciplinary actions or anything for the type of discrimination that they have said to patients.
And typically, like, people get away with bad behavior. Like, it's just, I don't know, at least in my experience, people get away from bad behavior. And part of that is, is it, I don't want to say easier. Is it easier to like ignore it if it doesn't impact you? But I think, like, many of the places in Canada, for example, are regulated. It's conduct unbecoming of a professional. It's like, these sorts of discrimination and bullying, like, that's not okay. And I think that, people have maybe kind of gotten away with it because there's staff shortages, and there's all sorts of things, but really, like, they shouldn't be allowed to if you like have your thoughts, whatever, but you shouldn't be allowed to voice those in a way that is like harmful to staff and or patients. And you know, I think if it were me, it's easy for me to say if it were me, but if it were me, I would run it up the chain, because honestly, it reflects poorly on everyone. If someone comes into your department and they have a bad experience because someone is ignorant, like that, look, your whole department looks bad, your whole facility looks bad. And I think that, you know, if common decency is too much to ask, like, you know, where are we? Like, that's a whole other conversation, but anyway.
I think, Megan, on top of that as well, I think people sometimes when they are making comments, they may not necessarily realize what it is that they're doing and the effect that it's actually having. And I think this is where it is up to all of us, I think, as individuals, to be calling out that type of behavior and just highlighting it to the individual to begin with, and just saying that, you know, that kind of talk isn't on. And I think that we need to, you know, maybe we need to talk about that in the future. But also, I think that, you know, individual departments can start looking at like education around this and what is appropriate behavior, and how can we look at this issue and that. So I think that by doing this research in the first place and really highlighting this issue, I think it's actually good, because it's a first step in terms of looking at trying to make that better for people in the future as well. I'm actually just going to finish off as well by quoting Amanda Balderston, who's put something on here, which I'm sure you all know, and that is that she says, I hope this webinar sparks more research and, most importantly, better care for this patient population. And I'd really like to echo that, because I think that is really, really important as well. To all of you, though, thank you very, very much for joining us on this webinar. It's been an incredibly important topic, and I'm really appreciative of all of the research that you've shown with us. For those who have been watching, and that this will be available through the ISRRT and through the CAMRT websites in the coming days or weeks, so that you can come back and watch it again. Thank you all for joining us, and good evening to all of you.